It's funny. In the ED, everyone always wants to talk about the airway.
Oh, absolutely. It's the big heroic moment, right?
It's the Hollywood moment, yeah. The alarms, the rush.
Right.
But if we're being, really honest about the day-to-day, our actual core business, it's not the tube in Resus 1.
It's definitely not. It's that lac in bed 4 that's been waiting for an hour.
Exactly. It's wound care. And looking at the sources we have today from UpToDate, LITFL, it feels like this is a skill where people they plateau.
That's a really common thing. You get good enough to close the hole, but you don't really master the artistry of it. You stop thinking about the tension vectors or the cosmetic outcome.
And the sources use this phrase I really like, owning the wound.
It's a great phrase. It's about being proactive. You're controlling the biology, not just reacting to it.
So today, we're going to try something a little different. We're not just listing steps. The notes mention this framework, PEL-OP. I guess it's from sports psychology.
Right. Physical, environment, task, timing, all of it. It's about creating a really high-fidelity mental simulation.
So we're going to apply that to suturing. We're going to virtually scrub in. So if you're listening, I want you to really visualize this. You're in the ED. You can hear the monitor beeping. You can feel the needle driver in your hand.
That physical and environmental piece is so important. You have to feel comfortable before you even start.
Okay, so before we pick up that driver, let's talk setup. The first decision is the golden period.
Yes. The idea that after 6 hours, a wound just turns into a pumpkin and you can't touch it.
We've all gotten that sign out, right? Came in at hour 7, didn't close.
Which is it's frustrating. The literature is way more nuanced. UpToDate suggests your window for most parts of the body is more like 12 to 18 hours.
That's a huge difference.
It is. And for the face, with that rich blood supply, you can push it to 24 hours, maybe even more. So it's more of a golden judgment call.
Okay, decision made. We're closing it. Now, anesthesia. The sources completely contradicted how I was taught.
Let me guess. You were told to poke the clean skin around the wound.
Always. But the sources say that's wrong.
It's biologically wrong. The intact skin is packed with pain receptors, the raw subcutaneous tissue inside the wound edge. Way less sensitive.
So the move is to actually go inside the cut.
Exactly. Visualize a 27 or 30 gauge needle. Insert it directly into the open wound edge. It's so much less painful for the patient. You win half the battle right there.
All right, we're numb. We've irrigated. Let's get into our first mental simulation, case 1.
The foundation. The simple interrupted suture.
The scenario is a clean, linear laceration on a forearm. Why do we even need to visualize this one? Everyone knows how to do it.
Everyone knows how to do it, passively. But to do it perfectly, you have to visualize the geometry.
Okay, so put me in the driver's seat.
Yeah.
I'm holding the needle driver. What's the mistake I'm probably making?
So most people, especially when they're rushing, they scoop the needle. They go in at a shallow angle because it's easier on the wrist.
Yeah, that feels more natural,
It does. But if you scoop, you create a V shape with the suture. And when you tighten a V, the skin edges roll inward. That's inversion.
And inversion leads to that ugly, depressed scar.
Exactly. So you have to force your wrist, really feel that physical twist, to enter the skin at a perfect 90-degree angle.
I'm visualizing that, a perfect right angle.
Right. Drive deep, creating a flask, shape wide at the bottom, narrow at the top. When you tighten that, it forces the tissue up and out. Version.
Eversion is the goal.
Version is king. You want the edges to pout a little because as it heals, the scar contracts and flattens. If you start flat, you end up with a ditch.
That's a great visual. And for spacing, to avoid those little dog ears at the end.
The trick here is bisecting. Don't start at one end and zipper it shut.
Divide and conquer.
Yes. Place your first stitch at the exact midpoint. Now you have 2 smaller wounds. Stitch the midpoint of those. Keep cutting the problem in half.
Okay, case 1 is closed beautifully. But let's up the difficulty. Case 2, a wound under a lot of tension. Over a joint, maybe?
Right. And a simple stitch is just going to slice through that skin like a cheese wire.
So you need a load-bearing stitch.
Okay.
The horizontal mattress. I always get horizontal and vertical mixed up in the moment. How should I visualize this one?
Think of it as building a box or a square.
A box. Okay, walk me through it.
Step 1 is just a normal stitch. You go across the wound, say left to right, but you don't tie it.
Okay, so the needle's just hanging out on the other side.
Right. Now, instead of tying, you reload the needle backhanded, you move about 1 centimeter down the wound, and you drive the needle back across from right to left.
Across, move down, come back.
Exactly. And when you look at the surface, you've created a square of thread. And that square distributes the tension along the edge, not at a single point.
And one of the sources calls this technique an assistant.
That is the absolute best way to use it. Imagine a really gaping wound, you're stressed, you just throw one big horizontal mattress in the middle to pull the edges together. Now the tension is gone.
And you can take your time with the simple sutures.
Yep. And you can even take the mattress stitch out at the end. It's a pro move that just lowers the difficulty setting.
I love that. Okay, case 3. We're on the shin of an elderly patient.
Yeah.
The skin is super thin, and it wants to roll inward.
The classic inverted wound. This is the perfect job for the vertical mattress. If horizontal is for tension, vertical is for eversion.
And the mantra here is far, far, near, near.
That's it. It's a 2-stage stitch. So let's visualize it. Far, far first.
Okay.
You start far from the wound edge, maybe a centimeter back. You took a huge, deep bite, and you exit far on the other side.
So that's the deep structural part.
Right. But the edges might still roll in. So now you reload your needle and you do the near-near. You take a tiny, shallow bite, just 1 or 2 millimeters from the edge, on your way back across.
So it's one big loop with a little loop sitting on top.
Exactly. And that little near-near loop acts like a lever.
Right.
When you tighten the knot, it physically lifts the skin edges up and rolls them out. It forces eversion.
But I've heard about the railroad tracks scarring with these.
Yeah, you have to be careful. You can't tie them too tight, and you have to get them out early. They are functional stitches, not cosmetic ones.
Got it. Okay, now let's go deeper. Literally. Case 4. A deep laceration on the thigh. There's fat exposed. It's gaping.
Dead space.
And dead space is bad because it fills
with blood, a hematoma, which is just a warm meal for bacteria. You have to close that space.
Which means we need a deep dermal or a buried suture. This is the one I think feels the most counterintuitive.
It does. First, you have to be using an absorbable suture, like Vicryl. You're not coming back for this one.
Okay, so let's visualize the inverted knot. We want the knot to end up at the bottom of the wound, not pushing up against the skin.
Exactly. So picture the canyon of the wound. You start on the near wall, the very bottom, deep.
Deep.
And you drive the needle up towards the skin surface, superficial. But you don't exit the skin, you stay in the dermis.
Okay, deep to superficial.
Now cross the canyon to the other side. You enter at the top superficial and drive the needle down to the bottom.
Deep. Deep to superficial. Cross. Superficial to deep.
You got it. And now, when you tie those two ends, because they're both coming from the bottom, the knot just slides right down into the abyss. It buries itself.
And if you've done it right.
It feels like magic. The skin edges on top should just fall together. All the tension is gone. You could close the skin with tape at that point.
That's the real mic drop moment in suturing.
It really is.
Okay, final boss. Case 5. The stellate laceration. That dreaded Y shape with a triangular flap.
This is a vascular nightmare. That little flap tip has a very fragile blood supply.
And your first instinct is to just put a stitch right through the tip to tack it down.
Which is the absolute kiss of death for that tissue. You'll strangle what little blood flow it has left. The tip will necrose.
So we need the corner stitch or the half-buried horizontal mattress.
Let's stick with corner stitch. It's easier to visualize.
Okay, how do we do it?
Picture the Y. You start your needle in the static skin, the part that forms the corner, not the flap.
Right. Needle goes in, comes out inside the wound, and I'm looking at that flap tip.
Now here's the key. You do not go over the flap. You go through it horizontally. You pass the needle sideways through the dermis of the tip, like you're making a shish kebab.
Wait, so the needle never actually pokes through the surface of the flap?
Never. It stays underground, in the dermis.
No.
Then you bring it back out through the static skin on the other side of the Y.
So the thread goes in the static skin, tunnels sideways through the flap and out the static skin.
Exactly. And now, when you tie your knot, the knot itself sits on healthy tissue. And as you tighten it, that loop just pulls the flap tip perfectly into the corner like a puzzle piece.
Without squeezing the life out of it.
It's elegant, and it saves the tissue.
So there it is. 5 wounds, 5 visualizations. Let's zoom out and summarize the key takeaways. First, decision-making and timing.
I think the big one there is just remembering the window, 12-18 hours for the body, 24 for the face, and matching your suture size to the location.
Right. Don't use a 3-0 on an eyelid.
Please don't. And irrigate, volume is everything.
Okay, next. Technical skill and physicality. If there's one single physical movement to master from today.
It's the 90-degree needle entry for eversion. If you don't evert, you invert. And don't strangle the tissue with your knots, just kiss the edges together.
And finally, non-technical skills and leadership.
This is huge. It's about communication, explaining scarring risks before you start, managing expectations.
And knowing when to call for help.
Exactly. If it involves the vermilion border of the lip or a flexor tendon, calling a specialist isn't admitting defeat. It's good leadership.
And document your neurovascular exam before you put the anesthetic in.
Oh, absolutely. If it isn't written, it didn't happen. You have to know the baseline.
Okay, so before we wrap, I want to leave everyone with one final thought from the readings. We spent all this time visualizing sutures. But are sutures always the answer?
That is the question, isn't it? The sources bring up tissue, adhesives, glue.
Especially for that elderly patient with a paper-thin shin.
Right. For that patient, the needle itself causes trauma. The tension from a stitch can just tear the skin. Sometimes, the best closure is actually glue and some steri strips.
We get so focused on the tool, we forget the goal is just approximation.
Don't be a one-trick pony. Sometimes the best stitch is no stitch at all.
I like that. All right, next time you pick up that driver, take a second, visualize the flask, visualize the vectors. Don't just close the hole, own the wound.
And try not to stick yourself.
Always good advice. Thanks for diving in.
My pleasure.
See you on the next deep dive. Stay curious.